Hello, everybody, and welcome to our webinar today on lower limb length inequality. My name is Aaliyah Beckor, and I'm the marketing coordinator here at Orthotic Holdings Incorporated. And thank you very much for taking the time to join us today. To start off, I would like to make sure that the audio is working and you can hear me clearly. You can activate the audio using a computer or phone. If your computer audio is not working, you can call in using the phone number and access code shown on the dashboard. Before we start, I'd like to explain a few functions on the control panel, which is on the right-hand side of your screen. There are a couple of icons, a microphone with a red slash through it, a square with a question mark, and a hand. The red slash through the microphone means you're on mute. The reason we do this is to manage the background noise. But we do encourage you to ask questions. Simply click on the icon that is a square with a question mark in it, and you should see a chat box appear, and you can enter your questions there. We will wait till the end to answer all questions, and if we don't get to your question today, we will email you with a response. Today's webinar is being recorded, and we will post the recording to OHI University within 24 hours. Our presenter today is Dr. Kim Ross. Dr. Ross received his PhD in biomechanics from the University of Waterloo in 2003 under the supervision of Dr. S. McGill. Dr. Ross graduated from the Canadian Memorial Chiropractic College in 1987. Since 1988, he has been teaching chiropractic skills and body biomechanics at CMCC and currently holds the title of Associate Professor. In 1999, he obtained the position of Chair for the Department of Applied Chiropractic. Since 1995, he has been invited to the National Board of Chiropractic Examiners in Colorado annually to help develop Part 4 of the National Board exams. He has been published in the journal Spine and Clinical Biomechanics. In 2003, he received an award as Researcher of the Year from the Ontario Chiropractic Association. He's presently the Director of Clinical Services and Research at the Orthotic Group. And Dr. Ross has lectured in Ireland, Australia, and Switzerland. His audiences include student chiropractors, chiropodists, podiatrists, physiotherapists, and faculty members at various educational institutions. And without further ado, here's Dr. Ross.
Thank you, Aaliyah. So welcome, everybody. Today we're looking at lower limb length inequality. When I think back through my career, when I started to recognize this issue in patients, it was almost mind-blowing because it allowed me to help a lot of patients that I previously hadn't been able to help on a long-term basis because I never really thought to check for a limb length inequality. And when I would ask patients if anybody had ever said they had a limb length inequality, it was never a healthcare practitioner. It was usually the patient's parent or the tailor that might have said that when they hemmed the pants that there was a difference from one side to another. So if you don't look for it, you don't find it. So we're going to learn today as to how to assess it, what are the pathological consequences if you do have a limb length inequality, and how do we actually treat it conservatively. All right, so most of this material comes from a review article that was done back in 2003 by Brady. So if you want to read up more on the details of this, this particular paper is chock full of details, which I won't go into many numbers because it can get a little tedious. But if you want to see the numbers, they are in this particular article in Journal of Orthopedic Sports Phys Therapy. So, two types of limb length inequality. There's anatomical and there's functional. Anatomical is defined as it occurs when a physical shortening of a unilateral lower limb exists between the head of the femur and the ankle mortise. So in other words, when there is a short femur or a short tibia, we call that an anatomical short leg. Functional short leg, on the other hand, is an apparent limb length inequality, and it can be described as a unilateral asymmetry of the lower extremity without any concomitant shortening of the osseous components. It can usually be addressed through muscle balance, manipulation, or orthotics as well. I mean, technically, a unilateral flat arch would be a functional shortening because the arch is flat on one side and not on the other. It brings the whole lower limb closer to the ground. So if you can restore the arch, you can restore the functional discrepancy. Now, that's as far as we're going to go into functional, because we're going to be talking about anatomical for the rest of the presentation. So the first question to ask is, how much of a difference is clinically significant? So you can see here we've listed 2, 3, 4, 5, 6, 7, 8. We had 9 different papers, and they had 9 different criteria and 9 different magnitudes, which they thought was significant. So Subotnick says if there's a difference of 3 millimeters, it requires intervention. Freiberg says, now it's okay at 3, but if it's 5, it's a problem. Holmes says, no, 5's not a problem either. 6 millimeters is a problem. Giles and Taylor say, no, 6 isn't a problem. You have to get 9 before you get back pain. Ten Brink said 10. Boosting and D'Amico say 11. Gibson says to produce scoliosis requires a 15 millimeter difference. Lamp said it induces impairment at 20. And then finally we have Papineau says, oh, when you hit about 22 millimeters, then we get scoliosis. So you can see we're all over the map in terms of what's significant and what isn't. My point is this: if the patient has symptoms, it's clinically significant. So it might be, for me, it might be 3 millimeters. If I've got a patient that isn't responding well to usual care, and I check out and think, well, maybe there's a leg length discrepancy. If I saw a 3 or 4 millimeter difference, to me, that matters. And I would intervene at that point. And in most cases, I found that a chronic back issue would go away. So my short answer to this question is anything that bothers the patient is clinically significant. So it's not so much the number of millimeters that matter. Now, how prevalent is it? How many people are walking around with a short limb? Technically everybody, right? So because it all now depends on what you consider as being significant. So if you measure down to the nanometer, 100% of the population has a leg length inequality. On the other hand, there's people that have said it's not really a leg length inequality until it's about 3.5 centimeters. Well, if that's the case, there aren't that many people with a 3.5 centimeter difference wandering around, so it won't be very prevalent at all. So as a result, because it depends on what one considers significant, the values of prevalence actually vary all the way from as little as 4%, that would be people that have a 3.5 centimeter difference, all the way to 95%, which would include people that would be in the 3-4 millimeter range. So what does it affect? Well, we're going to look at scoliosis, low back pain, and the effect of limb length inequality. So we're talking functional scoliosis here. We're not talking idiopathic. So Giles and Taylor examined the effect of limb length inequality correction on spinal alignment using radiographs before and after correction. All right. The investigators used 3 groups of subjects: young adults, middle-aged adults, and older adults. And I believe the middle-aged and young were under the age of 53. So I think 53 and older was considered old, which is bad because that means I'm old. So in the 2 groups of younger patients, the ones less than 53, the functional scoliosis was completely corrected or nearly corrected immediately with board lifts, so a lift that went inside the shoe, and remained corrected for 4 months of shoe lift intervention. In other words, the lift remained in the shoe. Now, in the older group, the correction of spinal alignment was much less and was not affected at all in many instances with lift correction. And so you got to ask yourself, Well, how could that be? I mean, if you bring the sacral base level, why wouldn't the scoliosis go away? Well, we're going to find out in a moment. Giles and Taylor found that when the difference was a greater than 9 millimeters, there was a scoliotic curve, as you can see here, convex to the short limb side. So the short limb's over here, and you got a convexity on that side. Then it straightened out completely when a lift was added. All right, so you can see the pelvis becomes level, the sacral base becomes level, and the scoliotic curve goes away. All right, here are actual X-rays. I'm not sure. This was done in 2018. I'm not sure how they got clearance to X-ray people just to see if a lift straightened somebody out, but they did. And you can see here, this is without the lift. You can see the pelvic unleveling. You can see the sacral base is on an angle, and because the sacral base is on an angle, L5 is going to sit on an angle relative to the long axis of the body, and L4 is going to sit on that, and then L3 is going to sit on top of that. So you can actually get either a C curve or a combination C curve, T curve. So after they put the lift in, you can see that the person straightened out substantially. Now, as I mentioned, the older group sometimes didn't respond at all in terms of the scoliotic curve going away. And the reason is this: if you've had a scoliotic curve for more than 50 years of your life, because of Wolff's law, your spine will actually change shape. Your actual vertebrae will change shape because there are asymmetrical forces going through the vertebrae. So what they have found is that these people actually have some vertebrae that are wedged shaped now because that curve has been there for so long. And therefore, if you try and straighten out the curve by putting a lift in, at the end of the day, that wedge is still there. And as long as that wedge is there, the vertebrae will be sitting on an unusual angle, and therefore the curve doesn't go away. So that's probably one of the main reasons that older people don't respond as well to lift therapy. All right, what about the hip? So Fisk and Bayet identified hip osteoarthritis, and Gofton and Truman identified hip arthrosis as common problems in the hip joint on the longer limb side. And the reason they speculate this is the long limb hip would be in varus, decreasing the surface area between the femoral head and the acetabulum, hence wearing the hip joint out prematurely. What about stress fractures and limb length inequality? Well, in a study of 371 Finnish army conscripts, Freiberg reported that limb length inequality may have a predisposing role in causing stress fractures in either the femur, the tibia, the fibula, or the metatarsals. So we know it can cause problems. So how can we sort it out? How can we determine if somebody actually has a leg length inequality? The first method is X-ray, and then there's two clinical methods to determine leg length inequality. One is direct and one is indirect. So we'll cover each of these in turn. X-ray, it is the gold standard. It still has error associated with it because of parallax. You can reduce the parallax by moving the tube back to 200 millimeters from 100 millimeters and making sure that the central ray goes right through the acetabulum. Otherwise, parallax will kick in and cause an inaccurate result. Now, of course, the downside to X-ray is the X-ray itself. So you have to ask yourself, is the condition severe enough to warrant exposing the patient to radiation? And you're going to see my conclusion is no, just because we're going to find out that when you do correct the leg length discrepancy, you're going to find that you only have to correct about half of it to make the patient's symptoms completely disappear. And because of that, you don't have to be terribly accurate as to how much of a difference there is from one limb to the other. If you were going to x-ray anyway to rule out some other pathology, then you get to kill two birds with one stone. So you might as well take advantage of the fact and do it standing if you're suspecting a leg length inequality, and therefore you can document the leg length inequality and any other pathology that happens to be present. All right, so here you can see you could measure it from the x-ray. Look at, I put a blue line here over the iliac crest on one side, put a blue line over the iliac crest on the other side, and you can see this little red set of brackets here would be the measurement that you would take. And of course, it would have to be to scale with the patient. This is not the real size of the patient. So, since I suggested that probably not needed to expose the patient to radiation through an x-ray unless we needed to x-ray the patient to rule out something anyway, let's now focus on clinical methods. All right, the first type of clinical method are direct measures, and this is probably what you learned when you were in school. So there are 4 different types of direct measures. You take out a tape measure and you go from the ASIS to the medial malleolus. You can go ASIS to lateral malleolus. You can actually go xiphoid process to medial malleolus, or you can go umbilicus to medial malleolus. These are all methods that have been used historically. So here's the ASIS to medial malleolus method. So you find the anterior superior iliac spine, you put the tape measure there, hold it down, and then you go to the tip of the medial malleolus and you measure the distance from one to another. Now, if you just look at, I put the picture in for a reason other than just so that you can see where the landmarks are and how it's made. What I want you to see is I want you to notice how the tape measure is undulating up and down as it crosses over various prominences. So you can see as it goes over the thigh here, it is actually convex here, and then it straightens out as we get down where it's not touching any body parts. There's a little blip as it goes over the patella. So in other words, there's an error associated with just putting the tape measure on the patient, because essentially you got a tape measure undulating up and down as it goes over bony prominences, making the accuracy of this questionable. Similarly, when you go from umbilicus to medial malleolus, we get the same problem. Although you're on the inside of the thigh, you probably won't rise up as high as you would on the middle of the thigh, but it's still not a straight line from umbilicus to medial malleolus, causing some error. So a great deal of criticism and debate surrounds the accuracy of these tape measure methods. Freiberg has reported cases for which an actual limb length inequality of up to 25 millimeters, that's an inch, has been overlooked and even attributed to the wrong limb by some clinicians, which means an error of 2 inches, which is really bad. Remember I said you can afford to be a little bit inaccurate, but not 1 or 2 inches inaccurate. So the other thing is direct methods do not take into account foot posture because the measurement stops at the medial malleolus. So the arch doesn't enter into it. However, when the patient is alive and walking around, the arch very much enters into it. So you could actually have a situation where they measured it, and let's say you could measure it accurately, they're going to say there's no difference. But when the patient stands up and he's got one flat arch on that side, that limb is functionally shorter than the other side. But you wouldn't know that if you use the direct methods because you're only measuring as far as the medial malleolus. And even if you did measure down to the bottom of the foot, the patient isn't standing, so the arch wouldn't be flattened out. So this brings us to the third possibility, and there's only one more possibility. We better hope that this one works, because if it doesn't, we're either going to give the patient too much radiation or it'll be too inaccurate. So let's hope this one works. Indirect methods for assessment of limb length inequality use palpation of bony landmarks, most commonly the iliac crest, anterior superior iliac spine, trochanter, things like that. And we do this while the patient is standing. So these methods involve assessing if bony landmarks are level or if limb length inequality is present. So simple palpation and visual estimate of iliac crest height is not reliable. So the patient's standing there, you put your hands on the iliac crest and you eyeball that there's a difference, and you would be accurate at saying there's a difference, because we are quite good at knowing when something isn't level. I mean, I'm sure you've walked into somebody's living room and wanted to fix the picture that's on the wall. Even if it's just a couple of millimeters out, you can see it. But you can't just look at it and know that it's 2 millimeters versus 3 millimeters versus 4. So the accuracy of knowing how much of a difference there is questionable. Knowing there's a difference, we're very good at. So that makes sense then to determine the magnitude of the difference is to try and put something under the patient's short leg until those landmarks become level. And because we're so good at picking off when something is level, all we have to do at that point then is measure the amount of material we put underneath the foot. And since one of the treatments for limb length inequality is heel lifts, you might as well use heel lifts as the marker, because we know how thick they are when you buy them. You put those under the foot until the most of the landmarks become level, and now you know how much of a difference there is from one leg to the other. So how accurate is it? Well, Warman and Binder-McLeod reported that the mean difference between iliac crest palpation using the block correction method, block correction meaning putting something under the foot of known thickness, compared to radiographic measurements was 2.2 plus or minus 2.6 millimeters. All right, that's a lot better than the 1 or 2 inch error that we talked about before. So they concluded that this indirect method was the most accurate and precise clinical method for determining limb length inequality, compared with the 4 direct tape measurements that they also included in their investigation. So to summarize how we examine the person for limb length inequality, results for the iliac crest palpation and block correction, and every time I say block correction, I mean putting something of known thickness under the foot on the short limb side. This appears to be more accurate and precise than other clinical assessment methods described in the literature. Now, as I said before, the nice thing is you'll find that in most cases, you only have to correct about 50% of the discrepancy to optimize the clinical outcomes. Therefore, absolute accuracy is not necessary. And since it's absolute accuracy is not needed, it's not worth the risk of a radiation exposure to improve the accuracy. So this is a student of mine from several years ago. She actually does have a short limb on the left side, and you can see I put lines in here. This is her iliac crest. You can see low on the left side. Here's the PSISs, low on the left side. Here we can see greater trochanters, low on the left side, and the gluteal crease, also low on the left side. And this is our ideal situation when all the landmarks are low on the same side, because that means there's been no pelvic adjustment, if you will, to try and counter the limb length inequality. So I'm not sure if you're aware of this, but you can actually functionally change the length of a limb by either anterior tilting or posterior tilting the pelvis. So if you had a short leg on the left side, you could anterior tilt that hemipelvis and posterior tilt the other hemipelvis to try and get the sacral base to level out, and that does happen in certain cases. If it doesn't actually help the patient as much, it's going to take the patient longer to respond to lift therapy, because you essentially, once you put the lift in there, the body will start to try and undo the compensations that it made in the pelvis, and that's going to take a little bit of time. So here's scenario A, as I said before, iliac crest low on the short limb side, PSIS low on the short limb side. If we spun her around, you'd see that her ASIS is low on the short limb side, greater trochanter low on the short limb side, and the gluteal crease. And in terms of the patient getting better soon, that's the scenario you want. You just put the lift under this foot and all these things go level, and the patient, in my experience, if they're young enough, is better within about 2 weeks. Now, you don't give them the entire lift all at once. You start with the lowest amount of lift that you can purchase and leave them in there for 2 weeks at a time. And each time you ask the patient, how you feeling? If they say a little bit better, then you put in the next lift. Leave it for 2 weeks. How you doing? A little bit better. Put in the next lift. When the patient comes back and says, that last lift didn't improve things beyond what you had given me before, then we use the previous lift as the amount of lift that we're going to permanently put on, for example, an orthotic, right? Because the last lift that I gave her didn't improve things anymore. Now, why not try and correct the entire thing? You can if you want, but the problem with lifts is they don't always fit in the shoe comfortably. And if you put too much lift in the shoe, now the patient will get lifted up to the point where their heel keeps slipping out of the shoe, which won't make the patient happy. So the other possibility is that the pelvis has tried to do something. So the guy that calls the shots here is the greater trochanter. You see how I've got the 4 stars there? If your greater trochanters are not level, you do have an anatomical short limb unless you happen to have a flat arch on that side. So if you see that the greater trochanter is low, immediately the next thing you should check is the arches. If the arches are level, are even, then you've got a situation where there is a short bone. If the arches aren't even, you might have a short bone, but some of the leg length inequality may be contributed to by the asymmetry in the arches. So in scenario B, it looks confusing because iliac crest high on the short side, PSIS high on the short side, ASIS low on the short side, greater trochanter, this is the guy that calls the shots, low on the short side, gluteal crease low on the short side. All right, so at the end of the day, this is the guy that's calling the shots. This will tell you which leg is short. Check the trochanters, then go down and check the feet. If the feet have the same arches, then the lower trochanter is the leg with the shorter limb. All right, so you can treat this with surgery, but not recommended unless the conservative approach fails. The conservative approach is to put in a heel. It's been shown to be very helpful, especially in cases of chronic low back pain. So most clinicians agree that lift therapy should be implemented in small increments. That's what I said. So go to your supplier and get a set of lifts in terms of width and height, and always start the patient with the thinnest lift, regardless of how much the discrepancy is, just to play it safe. The patient may not even notice the change in height from one to another. You're making the changes so slowly. And if you do it right, they will just keep getting better and better and better, usually within a month. And I said, younger people, it can be as fast as 2 weeks. You might have them come back with the first lift and say, my back pain's completely gone. All right, so I said this already, correction of limb length inequality usually need not be greater than 1/2 of the difference between the limbs to make the patient asymptomatic. And I'd say that's a good thing because the lift does take up room in the shoe, and Freiberg contends that lift correction greater than 10 millimeters requires an external shoe lift, because if you try to put more than 10 millimeters in there, you're going to lift the patient right out of their shoes, and they'll get blisters and they'll get annoyed. So essentially, you would have to send them to a shoemaker or a certified podorthist that can modify the shoe and put the lift on the outside. And if it's a lot of lift that has to be added, you would, this is why I suggest certified podorthist. If the sole gets too thick because of the lift, now you're going to need rockers built into the sole of the shoe. Otherwise, the patient won't be able to dorsiflex their metatarsal phalangeal joints because the material is too thick to bend. So you have to have a rocker built into it, and a certified podorthist could design the shoe to do that. All right, so here's a study, very recent study actually, 2019, correction of leg length discrepancy among meat cutters with low back pain. Now, why meat cutters with low back pain? I contend that anybody, if you're walking around, it's not too bad. And if you're running, keep in mind that you only have one leg on the ground at a time anyway when you're running. So I'm not sure leg length inequality is that critical to a runner, but someone who is standing, it is problematic. And most of my patients would tell me their back pain was worse, at its absolute worst, when they were at a cocktail party because they're standing still on both limbs. So it makes a lot of sense that a meat cutter, they're clearly not at a cocktail party, but they're clearly standing still for long periods of time. And I imagine auto workers would have a similar problem. So meat cutters with low back pain. So it was a randomized controlled trial. To be part of the study, they had to have at least a 5 millimeter discrepancy and at least a VAS level of 2 on a 10 centimeter scale of the visual analog scale. The leg length discrepancy was corrected to 70%. The intervention group wore the lifts 8 hours a day. There was 20 people in that group, and the control was without lifts, and there was 22 of those people. The primary outcome was low back pain. Secondary outcomes were sciatica and disability. In case you're wondering the difference, when you do an RCT, you're supposed to decide on your outcomes ahead of time and to determine how many people you need for the study so that you won't create a type 2 error in the statistics. You estimate your number of people needed to avoid a type 2 error with the primary outcome. So secondary outcomes often will not show up to be significant. If there is a difference, it's fuel, if you will, to do another study to make some of those secondary outcomes primary outcomes, and then you can power the study properly with enough subjects so that you avoid the possibility of a type 2 error. All right. So you can see here, this is low back pain on the VAS scale on the y-axis, and this is 12, it goes up for as long as 12 months. So baseline, then measured at 3 months, 6 months, and then finally at 12 months. And you can see here, this is the control group. You can see that there's almost no slope to that line because the control people weren't getting any better from a low back pain point of view. However, the blue line, which is the intervention group that had the heel lifts, you can see there's a negative slope to that line, indicating that the patients are improving. You can see that at day 0, they were scoring the average was scoring a 5 out of 10 on the VAS scale, and by the time a year had passed, they were all the way down to 1.5 on average. So this was statistically significant, the difference between the intervention and the control people. Now, as far as secondary outcomes go, The intensity of sciatica measured during the past week prior to using the RAN 36. There was an improvement in that. The sciatica pain decreased in the intervention group, but remained the same in the control group. Okay. All right, another study, and this one's pretty impressive. Lifts and low back pain, sciatica and hip pain. So Freiberg studied patients with a limb length inequality of between 8.7 and 12.3 millimeters, and this was actually determined by standing radiographs. What they found was that 73%, so 213 out of 290 people, 73% of the patients who previously complained of low back pain, sciatica, or hip pain reported they were symptom-free. Okay, 73% of them symptom-free. 15% of them, so 45 out of the 290, reported that their symptoms were reduced. So 88% of the people in the study were at least somewhat better, and most of them completely better at the end of the study. Only 12% reported no change in symptoms. So that takes up your 100%. And the good news of that is you'll notice that there's no group that said they got worse. So it's very rare for the patient to get worse following lift therapy. And even when it does happen, my experience is you take the lift out and the pain goes away within less than a week. So it's always worth a try, even with the 53-year-old. Just monitor him a little bit carefully because you don't want to aggravate him. But if he has horrible back pain or she has horrible back pain, it's worth a try to try the lift to see if it will help. Like I say, it may not, but at the end of the day, you got nothing to lose, really. You just take the lift out if it doesn't do the job. Okay. So in this study, patients were asked to use the magnitude of lift for 1 or 2 weeks and note any change in symptoms. And if positive effects were noted, then they got the next amount of lift. And they just continued this process until it didn't cause an improvement. And then permanent lift is the amount that caused the last improvement. And I said, if you're going to make the patient orthotics on top of it, the beauty of that is you can have it built, the heel lift built right into the orthotic. The cork lifts, as effective as they are, they're not effective for very long because they do squash and get bent over time. So you have to replace them pretty regularly. Whereas the extrinsic heel post that has a lift added to it will last as long as the orthotic lasts. All right, now I'm not done. I just got to pull up another presentation. It's only one slide, so don't worry. But it's a complicated slide. When you view this later, if I were you, I would just screenshot this and have a permanent record of it, because I don't think you're going to remember every single permutation and combination that I've put on here. Essentially, the permutations and combinations are based on the level of the greater trochanters, whether or not the arches are symmetrical, and whether or not an arch is flat or normal. So you got 6 different things to consider, and all the permutations and combinations of those things create this rather complicated chart. So let's start with a simple end here. You check the greater trochanter height. The arches are symmetrical and of normal height, and you've got level greater trochanters. So there's no anatomical leg length discrepancy. You check the PSIS, ASIS, and CRESS, and they're level. So you still have no anatomical or functional limb length discrepancy. So the symptoms are from some other cause. Now, if you check the PSIS, ASIS, and CRESS, and they are unlevel, but not all on the same side, but the trochanters are level, you have a functional leg length discrepancy only, and you should, if the patient has back pain, you should probably treat the back. So if they're getting pain in the SI joints, treat the SI joints if they're symptomatic. If they're not symptomatic and they have some moderate unleveling, I don't really worry about it. All right, now let's look at the situation where we have symmetrical but flat arches, so bilateral pes planus, and unlevel GTH, greater trochanter height. That means we do have a leg length discrepancy because this is the guy that calls the shots here. And we also have possible aberrant foot mechanics because we have flat arches. So in this case, we would probably give the patient foot orthotics and a heel lift to deal with the discrepancy. All right, let's come down this side now. Let's say we have symmetrical flat arches and level greater trochanter height. Well, this time we got flat arches and no leg length discrepancy. So because of the flat arches, if it's causing any symptoms, we would go with foot orthotics. Let's come down this side now. Let's say we have symmetrical but normal arches. So the height of the arches is normal and they're symmetrical, but we have unlevel greater trochanter height. Now we definitely have an anatomical leg length discrepancy, and there's two ways to go. And this is the two scenarios I told you about earlier in the presentation. All the landmarks are low on the same side. That means there's an anatomical leg length discrepancy with no pelvic compensation. There's pelvic unleveling causing the symptoms. Sacral base is unlevel with scoliosis to the convex to the short limb side. It'll respond quickly to heel lift therapy. On the other hand, if the PSIS, ASIS crests are not all low on the same side, it looks like we've got some pelvic compensation going on. In other words, possible anterior tilt on the one side and posterior tilt on the other side to try and functionally correct the leg length, the anatomical leg length discrepancy. You can still put a heel lift in there, but just remember, it's going to take a little bit longer to respond, because once the heel lift is there and the body seems to realize it doesn't have to alter functionally the leg lengths to try and compensate for the short limb. Once it realizes that, it has to undo the pelvic compensation. So it probably takes twice as long for the patient to get better as the patients in this group over here. Okay, we got two left. Patient has asymmetrical arches and level greater trochanters. Okay, well, this would mean that they actually do have a leg length discrepancy, but it is hidden by the asymmetry of the arches. And some people even argue that this is a real compensation that the body attempts to do. So if they have on the long limb side, the body will try and flatten the arch on that side, and on the short limb side, they'll try and increase it. So they do have a discrepancy, but the sacral base is level because of the foot compensation, if you will. So if you do correct the arch with the orthotics, the GTH will now become unlevel, and now you'll have to correct with a heel lift. All right, so it'd be a two-step process. Our final possibility is asymmetrical arches. So one arch is high, one arch is low, and unlevel greater trochanter heights. Essentially, as soon as you treat the arch with the orthotics, the greater trochanter should become level, and you're done. You don't even need a heel lift. All right, so like I say, I would suggest a screenshot of this when you're playing it, and perhaps we can even send a PDF of this out to anybody who would request it. All right, thank you. Any questions?
Thanks, Kim. Yes, we do have a couple of questions, so I'll go ahead and start with the first one. The first one was in relation back to the in the beginning of the presentation, when you were talking about the measuring the leg lengths. Wouldn't the error in measurement be equal on both sides?
except for one problem. People aren't symmetrical themselves. So the landmarks, the two legs, one thigh is bound to be thicker than the other. I mean, we are grossly symmetrical beings, but when you get down to it, on a fine detail, we are not absolutely symmetrical from one side to the other. If you, I think the thing that will bring this to your attention is look at somebody that you know very well, their face you see all the time, and look at them when they're looking in a mirror. Look over their shoulder. I know that's supposed to be bad luck, but anyway, they will actually look different to you when everything is reversed because of the small asymmetries in the body. So you're largely correct, but it doesn't take much of an asymmetry from one side to the other in terms of muscle bulk or bony prominence to create an error. The other problem is that there's errors associated with actually finding the landmarks and making sure you're at exactly the same spot of the landmark on both limbs.
Okay, great. The next question is there any other material besides cork do you recommend for intrinsic heel lift?
Yeah, some companies make a rubber lift. I find those last much longer. I'm not sure which companies offer them. I believe OHI does. I know the Orthotic Group arm of OHI does have lifts, but I believe their lifts are cork. But yeah, if you, I think the company that sells a lot of things for feet is National Shoe, is my recollection, but I can confirm that at another time and let you know. But yeah,
Yeah,
there are rubber.
we can get back to you on that question.
Yeah, okay.
And then the next question is, how do you suggest measuring for flattened arches?
Okay. So if you've taken any of the other courses that we've offered, it's we're not talking about measuring
Notes. You know what? We will just I can get back to this question and we'll just email a response. So for those of you that can hear me, hopefully, thank you all for joining today, and don't make sure you don't miss our webinar next week. That is shoe fitting, history and in practice, and that will be Dr. Ross and Dr. Al. And we look forward to seeing you all next week. Thank you very much.